everybody. I hope that no one feels like going to sleep now that we've had a wonderful lunch. I'm going to just review some things related to medical treatment of Cushing syndrome based on some of the focus group questions that came forward, and then my colleagues are going to talk about individual drugs. So I just put this up here not for you to look at every single line, but to concentrate on that left-hand corner panel, which basically says if you fail surgery, you can't have surgery, then, or you have an unknown or occult tumor someplace, one of the options to consider is medical therapy, because as we've been stressing, it's very important to control hypercortisolism in order to normalize all of the comorbidities. And so this is taken from the Endocrine Society treatment guidelines. So for anybody who likes to read sort of more primary directed literature in terms of what we say to physicians, this is probably one place you could start. So in the medical therapy of Cushing syndrome, we have a number of potential options. We can direct treatment against the ability of the adrenal gland to make steroids. We can have agents that are directed against the pituitary gland's ability to make ACTH. Or we can have currently just one agent that is directed towards the ability of the cortisol to bind to its receptor and exert its action. And we'll be talking about all of those as we go on. So you'll be hearing about cabergoline and pasireotide as pituitary-directed agents. We've grouped the steroidogenesis inhibitors into the old and the new. So the old are the ones that are currently available, ketoconazole, metirapone, midutane. For those of you who know about etomidate, the only parenteral IV formulation, we're not going to talk about that, but I'm sure can take it in questions. And the up-and-coming ones are levoketoconazole and osilodrostat. You'll hear about that. And then the receptor-directed agent is mifepristone. So the focus group asked some questions I thought were perhaps ones that I could take a shot at because they're more generic questions that go across all drugs. So the questions were how do drugs, quote unquote, get started, how to find out about the drugs, how much experience is there with the various drugs, and how do we know there won't be long-term toxicity? And so the speakers may go into some of that for their individual drugs, but I thought I'd tell you a little bit about how drugs get started. And we have another session after this where I think you'll hear stories from individuals who have done this. But I've taken 2 drugs through extensive drug trials, and one is in market now, so I've had a little bit of experience with this myself. So one of the ways it gets started is that an investor or a company, an investor, you can see where I'm going for the next session. An investigator or a company has an idea, it's usually based on physiology, about how to reduce the amount or action of, in this case for Cushing's, the action of CRH, ACTH, or cortisol. So the CRH inhibitors have been the holy grail for a long time. I don't think any of them have panned out yet, but so we're now really talking about ACTH or cortisol. So then they figure out how to synthesize something or find such an agent. They test it in the cell system to see if it has the properties they're looking for. They test it in animals. In the United States, you apply for an investigational new drug application, an IND at the FDA, or you can apply to the European agency for the equivalent. You test it in people, you publish it, and then you go back to that agency and ask them to approve it for that purpose. That's what we call labeling. Or you recognize that if it is available in the country, that it may be used as a quote-unquote off-label use, which means that physicians may use drugs that are not labeled by the regulatory agency for a purpose, not on that label, if there's sufficient evidence in the medical literature to justify that use. So we as physicians can't just go around willy-nilly picking out drugs and giving it to people. That's not considered appropriate, but we can use things off-label. So examples of this type of approach are levoketoconazole, because it's a takeoff on ketoconazole, so it's something we already know about. Pasireotide is something we know about, and mifepristone was found to be a glucocorticoid antagonist. So I put this slide up just to not confuse anybody, but just to say these are the kinds of things that people think about when they're looking at agents that might affect ACTH. So you can see at the very bottom, there's a line that says POMC gene. That is the gene that gives rise to ACTH and a number of other products. And you can see all of the different agents at the cell membrane surface that then are involved in regulation of that gene, and then all the various transcription factors and other forms of peptides that could be modulated to affect ACTH production and potentially secretion. And in this particular case, If animation comes up, which it doesn't seem to be wanting to do. Oh well. What I was going to show here without animation, I'll show you with my little pointer for those of you on the right-hand side. This SST is the somatostatin receptors 2 and 5 are prominent on the corticotroph, the ACTH-secreting cells, and dopamine receptor D2 is also prominent, and that forms the basis for pasireotide and cabergoline use in Cushing's disease. There we go, finally. So a second way that you might get a drug, quote unquote, started is that an investigator or company has an idea based on an unexpected finding from a currently used drug. Then they work to figure out, did it really kill people because it worked on cortisol? They tested in animals, and the whole rest of the process is basically the same. So ketoconazole is an example of that. Ketoconazole was found to cause gynecomastia when it was used initially, and some bright person said, oh, gynecomastia, maybe testosterone is altered, and it was, and then they said, oh, well, there's that steroidogenesis cascade, so maybe cortisol was involved. And so the people worked that out very early on and found out that ketoconazole not only is an antifungal, but also inhibits testosterone production and cortisol. And etomidate, the same thing. People died when etomidate was given for induction of anesthesia in the ICU. And folks said, gee, I wonder why these patients died. And they figured out ultimately that it was inhibiting cortisol production. All right, how can you find out about the drugs? These are just a couple of ideas. You've heard some others before. So UpToDate has patient information and lists other places to find information, and that, I'm hoping, made it into your handout. So the patient information sheets with UpToDate. You can do a PubMed search. That's going to give you the scientific articles that are available freely. Conferences, your doctor. Also, you've heard about clinicaltrials.gov, and the trials that are testing new agents will sometimes have references there, or you can contact the investigators. Then the question became, how long have these drugs been around? Well, what can I find out about them? Well, the quote-unquote older group tend to be less expensive drugs, and those are the steroidogenesis inhibitors. There's a lot more experience with that, but most of that is less rigorous. Most of it was not done prospectively, where we decide what kinds of patients to study and how to study them. So people tend to write up their good experience, and that tends to bias in favor of the drug and against full disclosure of adverse events. The newer and more expensive drugs, so pasireotide, mifepristone, and cabergoline, there's less experience, but much more rigorous studies. You're going to hear about those studies. These are prospective studies with a specific patient population to be included. The caveat there is that they may be less generalizable to all patients with Cushing's syndrome if the inclusion criteria were relatively conservative and excluded a lot of other patients with that illness. And the quote-unquote just approved drugs, we're really very limited to the type and number of patients in the study or studies that were used to justify the approval, and you're limited to understanding about the dose and schedule of administration. So if you want to try that drug in a different kind of patient or at a different dose or different schedule, you're not going to necessarily know whether there might be unforeseen side effects or whether it might work better. How do we know there won't be long-term toxicity? Well, if you use a drug within the dose and duration of published studies, and those studies include the adverse events, and they're large enough, you can be pretty sure that you won't see a lot of new toxicities. But toxicities can be very rare. For example, death from liver failure for ketoconazole was found after it went into general use, and it occurs in about 1 out of 10,000 patients who receive the drug. That was not something that we knew about when the initial studies were done. And again, if you use any of these drugs at different doses, different patients, different lengths of time, you can't really predict. So it is a risk, but it's one that you should be able to talk about with a physician, and most of us, I think, prescribe within what is published. The most important thing to think about this is the risk-benefit ratio, meaning there's always risk. There's nothing that isn't with risk, right? We just went and ate a whole bunch of carbohydrates. What's that going to do to our pancreas? We walk across the street. The Uber cars are coming very fast. I mean, everything has risk. But is there a benefit to what we are using the drug for? And that's always something you should be able to ask your doctor about and decide whether you want to take on that risk for that potential benefit. I think that is my last slide. And so we are next going to turn to Dr. Tritos, who's going to tell us about older steroidogenesis inhibitors. And by the way, we're going to plow right through this, and then we'll take questions at the end.
Okay, thank you, Dr. Niemann, and good afternoon. So I like the emphasis on older because indeed these drugs have been available for decades, and they were used initially for other reasons besides lowering cortisol. So just by a show of hands, these are the drugs we're going to talk about. We could even skip etomidate if we don't have time. How many of you are familiar with all of them? So a few. Okay, so I'll try to make this as simple as possible. So these drugs, they have some things in common that are worth talking about. All of them work by blocking one or more steps that are involved in making cortisol in the adrenal glands. They work by blocking enzymes. These are proteins that speed up specific chemical reactions that are essential in order to produce cortisol, and I'll show you a little bit of information. These drugs can all be effective in controlling cortisol regardless of the tumor type that causes Cushing syndrome. So they can work both for pituitary, ectopic, and adrenal causes of Cushing's. They're usually used in practice as second or third line treatments, typically after surgery, oftentimes in patients who have undergone radiation therapy and are waiting for the effects of the radiotherapy to kick in. Sometimes they can be used before surgery to bridge a patient, to improve their clinical condition and help them get through to that place so that they're safe enough to have surgery. And the dose is generally adjusted towards maintaining normal 24-hour urine-free cortisol. That's what's most frequently done in practice. Some may lose effectiveness over time. All require careful monitoring for side effects, some potentially serious, and Dr. Niemann alluded to that already. And all of them virtually have the potential to lower cortisol too much by blocking those enzymes more than is necessary and can cause hypoadrenalism, low cortisol levels, which can be, of course, very serious and potentially life-threatening. And virtually none of them are approved by the FDA to treat pituitary Cushing's specifically, although mitotane is approved for adrenal cancer. So in general, it's a fair statement to say that their use is off-label in these patients, and Dr. Niemann discussed what that means. So without trying to confuse anyone, but I wanted to point out that this is how the adrenal cortex produces steroids. The starting building block is cortisol, and through a series of chemical reactions, it goes down to cortisol, aldosterone, and then male-type hormones, androstenedione, testosterone, DHEA, and so on. And each of these steps is mediated by a protein called enzyme, a specific enzyme that speeds up the reaction enough to sustain life and make this practical in the body. And different drugs work by blocking one or several of these enzymes. Some may work down here towards the end, some may work at various different steps. So that's how these drugs work. So they don't do they don't treat the pituitary tumor that may cause pituitary Cushing's or the ectopic tumor. And except for mitotane, they really have no effect on even adrenal tumors. So let's talk about ketoconazole briefly. So this is a very old drug, introduced as an antifungal, and as Dr. Niemann said, later found to have useful activity to lower cortisol. So does it work? Keeping in mind that ketoconazole, as well as all the other drugs, have not been studied in prospective clinical trials. So this study is a retrospective one that was published relatively recently. 200 patients, this was done in France, several centers in France. Patients treated with ketoconazole, average dose 600 milligrams daily in divided doses. And they were treated, those at least in whom the drug worked, for about 27 months. And so how did it work? So you can see that about half of the patients had normal 24-hour urine-free cortisol during treatment. Another quarter, 25% approximately, had some improvement, 50% or greater improvement in cortisol over baseline. And another quarter had no improvement at all. And importantly, about half of the patients showed improvement in blood pressure, blood sugar, potassium levels. So it really helped their overall. We have some evidence that it really helped their overall condition. How safe is it? Same study, about 20% of patients stopped the medication because of side effects. Liver inflammation is a significant concern. 13% of patients had mild liver inflammation, high numbers of liver enzymes. More severe inflammation in 2.5% of patients, again by the numbers mostly, higher liver enzymes that were thankfully in this study, they were reversible. When the drug was stopped, they came down to normal. In this study, thankfully, there was no fatal hepatitis, although Dr. Niemann told you already that this can happen. Unfortunately, it's not common. It's rare. It's relatively uncommon, but it's something that requires a lot of vigilance on the physician's part. Other side effects: upset stomach, adrenal insufficiency, like all the other steroidogenesis inhibitors, skin itching, headaches, low testosterone, gynecomastia you already heard about. So, in fact, the FDA has required the insertion of a black box warning in the medication label to inform patients and physicians of the potential risk of serious liver injury and recommending regular and, in fact, weekly monitoring of liver function. That you can argue, whether this is practical necessarily, but that's the recommendation. And the FDA came from the position of the authority that has really labeled this drug to be used as an antifungal agent. They were not thinking of Cushing's because this is not even part of the ketoconazole label. So this is an important issue to be aware of. Another issue with ketoconazole, there's a potential for interaction between this drug and other common medications, such as statins that patients may be taking, antibiotics. So it's really very, very important for patients who take this drug to let their doctor know everything else about all the other medications they are taking, because some of them may be conflicting significantly. A few words about metirapone. Again, very old drug. It's labeled as a diagnostic test for Cushing's, not really for cortisol lowering. Does it work? This is a study that was published a few years ago from the UK, about 200 patients, the Cushing syndrome. About half of them had pituitary Cushing's, others had other causes of Cushing's. Treated with metirapone in divided doses, usually has to be taken 3 or 4 times a day, for an average duration of 8 months. And you can see that in this study, about 55% had what's called cortisol day curve normal. This is done in the UK mostly, so they measure cortisol several times during the day, and they have norms that they compare it to. 40% of patients had normal urine cortisol. So this drug has also been used during pregnancy, although it's not specifically labeled during pregnancy, but there is some experience that seems to be relatively reassuring that it can be tolerated and effective during that time. How safe is it? In this study, a quarter of the patients developed side effects: upset stomach, nausea, dizziness, adrenal insufficiency can occur. And then, because this drug leads to an increase by the way it works, it raises the male-type hormones. It can cause hair growth in unwanted places and acne, especially in women. And then in patients of both genders, it can raise blood pressure, cause fluid retention, low potassium, because it also leads to accumulation of other precursors of the adrenal steroids that have salt retention effects. A few words about mitotane. Mitotane is a very similar chemically to an old insecticide, DDT, in fact. And in the US, it's approved by the FDA to treat adrenal cancer because it actually leads to adrenal tumor breakdown. We call it adrenolytic, the effect of this mitotane. But in addition, it lowers cortisol. And although in this country it has not been used so much to lower cortisol, primarily because of the side effects, and I'll get to that in a point, it's been used a lot in France for that purpose, just to lower cortisol in patients with benign causes of Cushing, such as pituitary Cushing's. And these are, in fact, some findings from a study from France: 76 patients with pituitary Cushing's treated with mitotane. And you can see that 72% of these patients had normal urine cortisol and, in fact, developed hypoadrenalism at about 6.5 months, 6.7 months. Blood pressure went down, blood sugar went down. However, their cortisol increased, and that's a known side effect of this medication. And importantly, the effect was not permanent in this case. Well, of course, it isn't permanent for ketoconazole or metirapone either, but I told you about mitotane that it can often lead to breakdown of adrenal tissue. In this case, 71% of patients recurred after the drug was stopped. What about side effects? Lots of side effects. 29% of patients had to stop it. Nausea, diarrhea, liver inflammation, neurologic symptoms, high cholesterol, some decrease in white cell count, skin rash, and others that I don't have time to mention. So it's not always an easy drug to take, and that's what has made it less palatable. In addition, it's teratogenic, and in fact, because it's stored in the body for months, many months, as a matter of fact. And even if you stop the drug, it stays in the body for a while. It's actually recommended to delay pregnancy, to defer for 5 years after stopping the drug. So it's another reason why it's not so popular. A few words about mitotane. about etomidate. This is actually an anesthetic, as Dr. Niemann alluded to, and it has been used usually for short periods, but that can vary, but essentially in patients with very severe Cushing's, who have very, very severe symptoms, and they really need to get well enough to go to surgery. So this is, these are data from a recent small study. Usually it's done in small studies because this is used very infrequently, and it's always in the inpatient, almost always, I should say, in the inpatient care setting. So 7 patients treated for 9 episodes, severe Cushing's, 4 ectopic, 2 pituitary, 1 adrenal cancer. And you can see that cortisol went down really precipitously from 105 to 15.8 micrograms per deciliter within a day and a half, achieving target levels in almost everybody. So it can work really quickly and can be life-saving in selected patients. But these patients typically require ICU monitoring because the drug can be anesthetic, right? So in low doses, it can still lower cortisol, but still requires monitoring, nausea, vomiting, and other side effects. It can cause blood clot where it's administered, kidney damage, low blood pressure, some neurologic symptoms. So it requires a lot of care, and it's not a commonly used drug. Certainly, it's not used in the outpatient setting. So in summary, the older steroidogenesis inhibitors are still widely used to treat Cushing's, including pituitary, generally as a second or third line treatment, and can be effective and sometimes even life-saving in controlling cortisol excess. They can be helpful to in controlling cortisol levels, especially patients who had radiation therapy. That's the most typical scenario. None of them treat the pituitary tumor that causes Cushing's or the other tumors that may cause Cushing's, with the exception of mitotaine that also helps control adrenal cancer tumor growth. And all these are used off-label to lower cortisol, require very careful monitoring. And in fact, the speakers that are coming after me will talk to you about newer drugs and also drugs under development, which might eventually render some of the drugs I talked to you about obsolete. Thank you for your attention. I'll take questions at the end.
Let's see, I have to change the slides. In between, while I open my presentation, I wanted to thank you, all of you, for being here, and thank you, Leslie, for inviting us, but also for running this foundation. This is one of the best foundations that I have seen in years. So thank you so much for all your work. So my job is a little bit easier. You heard before about off-label drugs. That means that the drugs were approved by FDA for other indications. So now I'm going to talk to you about drugs that are not even approved. Okay, so you heard that. These are my disclosure. The research support goes directly to the institution, and the scientific consulting fee for being in the steering committees for these medications and studies I'm going to show you is my disclosure directly. So I recently found a quote that applies to all of us endocrinologists, and you being patients have seen many endocrinologists that are looking at numbers. But what is a number? Measure what is measurable, and to make measurable what is not so. So let's see if with some of the studies we are able to try to find out what's going on with all these drugs. So first I'm going to present you the levoketoconazole. The phase 3 data has been published, so you're not going to have access to these particular slides because I'm also going to show you some unpublished data, but the paper itself for levoketoconazole has been published. So ketoconazole is a racemic mixture, and the levoketoconazole that I'm going to show you a little bit of the data, not all our work for several years, is the 2S4R enantiomer. So you see the formula is similar, but not exactly the same. So Dr. Niemann said earlier that it's very important when you're looking for a study to see who has been included in that study to actually look at the results. Because if you look at the retrospective, these were already selected patients that all us doctors discuss with the patients. I think this drug is going to work for you. For a prospective study, it's a different story. And you can see here that the patients overall were the age for Cushing's, the more female, because this was mostly Cushing's disease, but was very important because this was a large international study. Look here, almost 30% of patients did not have surgery. So in Europe, keep in mind, I don't know how many of you are from Europe, they are using medications or before surgery, or waiting to be scheduled for surgery, or just sometimes as primary medical therapy. And if you're looking at these graphs, I don't want you to look at all the details, but just to see the trend. So you can see that patients that were on a lower doses, and I'm going to show you more numbers, most of them responded. Patients that require higher doses, that was a little bit more complicated. How about percentages overall? Keep in mind, you can't compare too much with retrospective because this was, everybody was included. So for everybody that was included in this study, the primary endpoint was 30%. So 30% of patients responded. However, if we're trying to compare with other prospective studies that you are going to see soon, that my colleagues are going to present, that we looked with numbers, if there were some missing urines, then the data was imputed there, it was 42%. So just so you are able to compare overall. What was interesting was that looking at, this was prospective, looking at the cardiovascular markers, and you have here a long list, they improved significantly. Now what significant means, this was statistically significant. So for some patients might be clinically significant or not. Keep in mind, this is statistically significant improvement overall. How about liver issues? You heard the liver problems with ketoconazole. This was a prospective study where patients had frequent liver panels checked. And any of you participated in this study? No. How about the oscillodrostat? Oh, one. How about the oscillodrostat study that I'm going to show later? Maybe you should say your experience later, but not right now. The liver-related adverse events overall, as defined in the protocol of special interest, so it's by the doctors, were as percent 7%. However, when we looked at the numbers directly, you can see that 31% of patients had some elevations up to 3 times upper limit of normal, and 3% had more than 5 upper limit of normal. What was very important, and we all looked at that, was how reversible it was. So everybody that had abnormal liver panel, including the one with higher elevations, when the drug was stopped, that reversed to normal. So as you can see, this was very reassuring because that's one of our worry for all these drugs overall. How about clinical improvement? So this data is not all of it in the main manuscript. I presented it the days earlier this year, but I wanted you to see from patients' point of view that when we look separately from the acne global score for the hirsutis for women and also for the edema, look at the graphs. This is all patients included. Of course, for hirsutis, it's just women. Look how it's coming down. It's true, some of the numbers are going down, and usually even in prospective, it's a little bit of bias related to the fact that patients that are doing well are staying in the studies, but that's all we have. We don't have data that's better than that. And for the edema, also some improvement and then stagnating. How about the quality of life? This was an open label study, so of course the patients knew what they were taking, but as you know more than us if the drug is making you feel better. Yes, we know numbers, but we have to think more of what the drug is doing overall. So you can see that the Cushing's quality of life went up, and this is the depression score that went down. Not having a control, as you heard earlier, it's a little bit more complicated, but this is also very important when we're looking at the treatment and follow what Galileo said. I'm switching gears right now and talk to you briefly about another drug that's on the horizon, oscillodrostat, that also works as an adrenal steroidogenesis inhibitor, so blocking the cortisol at that level. And what's interesting, it's not just blocking the 11-hydroxylase. You remember the graph that Dr. Tritos showed you. I'm not showing it to you again, but it's also affecting the aldosterone production. So this might have some effects, and I'm going to show you a little bit, though I'm limited by what I can say because not everything is publicly available yet. However, the phase 2, we published it a while ago, and I just want you to look at the trend. So these were all patients that were in the studies. This is where they started, and this is what they achieved. So the urinary free cortisol went down significantly. However, as we expect, and not everybody responds, and if you are going to ask me how do we know who's going to respond, that's going to be the question that I'm going to say, I have no idea yet, unfortunately. We're looking at some predictive methods and models. The ACTH, this is blocking the cortisol, so the ACTH is going to go up. How high? This is a mean of all the numbers, so in some patients it's getting higher than other, but this is something important that we have to keep in mind. The phase 3 study has been presented now multiple times, the last time in Cape Town, and I wanted you to, for comparison, to look at the numbers are the same. This was much larger, but the same type of population. A lot of them primary treatment, most of patients women. Again, this is Cushing's disease that we are talking about. This study had a little bit different design. I'm not going to go in all details, but just I want you to look at it. This was compared with patients that did not take drug at some point. Not immediately in the study itself, the patients were stopped from the drug. So if you're looking at the patients on the left are the patients that are under drug, and you can see almost everyone went down with few exceptions of patients that went up. And on the right, you see the patient that at some point the drug was stopped. And of course, there you see that most of them went up, but very interestingly, not everybody went up. So this is a lag in between stopping the treatment and then when do you have higher numbers again? We don't really know. If we're looking at clinical improvements, the same thing. We can see that the systolic blood pressure is going down, the diastolic, the weight, the waist circumference, and then also improvement of glucose. So we see clinical improvement. And furthermore, mimicking what I showed you earlier, you can see that the quality of life is also improved with treatments. In conclusion, though I showed you new data for new potential medications that have not been approved by FDA yet, so we cannot even use them off-label, I think that surgery still remains first line, and I'm sorry that Dr. Esiku left to hear us that we still depend on surgery. After the first surgery fails, we have a lot of treatments, and medical treatment should play an important role, sometimes even before a repeat pituitary surgery that has its own risks. And there are a lot of pros and cons that I'm sure you're going to ask us more later. Thank you so much.
Okay, so I'm going to discuss tumor-directed medical therapy. I showed you my financial relationships yesterday. So as we've been talking about, there are various targets for treatment for Cushing's disease, and I'm going to discuss the treatments that work on the pituitary gland and the pituitary tumor itself. So this refers to people with Cushing's disease from a pituitary tumor. So we use cabergoline to treat Cushing's. You may know that cabergoline is the first-line treatment for people with prolactin-secreting tumors, but we also use it for Cushing's. And there have been no systematic trials of cabergoline use in Cushing's, but we have a number of studies, retrospective and prospective studies that have been done looking at cabergoline and Cushing's. And this was a paper that was published recently, and it summarized the prior work that had been done looking at cabergoline and Cushing's. And you can see that, if I can find the pointer, these are both retrospective and prospective studies, so we're kind of looking at a range of data quality, some just looking back and some looking forward. These were small studies, so 10 to 30 people in each study were included, and a range of doses were given. So this is very different type of data than what Dr. Flisario was just presenting, which was clinical trial data. So you can see that people receive 2 up to 3.5 up to 4.7 milligrams per week. The response criteria that was looked at, and most of them was 24-hour urinary-free cortisol. So it was looking to see if the cabergoline normalized the 24-hour urinary-free cortisol, except one study that used a midnight cortisol or low-dose dexamethasone suppression test. And they found a range of responses. This study found that no patients responded, but it was only a 6-week study. And for the most part, it was between 25 and 40% of the people responded in terms of achieving a normal urinary-free cortisol. Again, these were smallish studies and kind of short. They weren't followed for a long period of time. This study followed people for just 6 weeks, and most of these studies were less than a year of follow-up. But in summary, for Cushing's, like I said, there have been no clinical trials. These are observational studies. But in general, we see that 25 to 40% of people achieve a normal urinary-free cortisol. There's a range of doses that are given. We tend to use higher doses for Cushing's than we do for a typical prolactin-secreting tumor, and higher than kind of the typical dose range, and sometimes up to 1 milligram daily. We don't have a way of predicting who's going to respond, unfortunately, and some people respond pretty quickly, and some people take a little longer to respond. Some people respond but then escape. So you can see that this figure shows long-term response to cabergoline monotherapy in 8 people who had responded, and they were treated for more than a year. And you can see that this is their urinary-free cortisol, and that a number of people, their urinary-free cortisol decreased, but then it increased over time, and we're not sure why that is. In terms of side effects, there can be some dizziness, some fatigue. I tell people to take it at night before bed. If you're feeling tired and dizzy, you can go to sleep. Some people have some gastrointestinal side effects like nausea. Another thing that's come up is the effect on heart valves, which is sort of a complicated story, but a paper was published more than 10 years ago looking at Parkinson's patients who take this same medication. They take it at much, much higher doses than we typically give. They take about an average 3 milligrams daily, but it was shown that in Parkinson's patients taking a much, much higher dose, there was a risk for developing changes in the heart valve, so thickening and regurgitation in one heart valve in particular. It was thought to be a cumulative dose effect, meaning if after they were exposed to more than 1 to 2,000 milligrams of the medication, they were at risk. So we got very concerned in the pituitary world when we saw this paper. What about our young, healthy patients who take very, very small doses but for a long period of time? There have been a number of studies published looking at our pituitary patients taking this medication, and for the most part, they have not shown that same risk for a change in the heart valve. However, recently there were a couple case reports suggesting they're showing that a couple patients have had a change in the heart valve. So you should, if you're taking cabergoline or considering, talk with your doctor about this issue. What can be done is getting a screening echo of the heart, an ultrasound of the heart, and that can just be followed over time. I don't do it routinely in all my patients taking cabergoline, but I will consider doing it in someone who, one, is at risk for heart disease, an older patient, or someone who's on a high dose of medication who's taking it for a long time. But it's just an ultrasound of the heart that can be done. But overall, we consider that this medication is safe to take, and it's effective for some people, particularly people who have larger tumors where you want a tumor-directed therapy. So I'm going to move on to the second drug that I'm discussing, which is pasireotide, as you've heard a little bit about. So pasireotide is a somatostatin receptor ligand, meaning it works at the somatostatin receptors in your body and in the tumor. And I will say that both of these therapies take advantage of the receptors that are present on the ACTH tumor. As you can see here, there are 5 somatostatin receptors in the body, and pasireotide works on 4 out of 5 of those receptors. It has a particularly high affinity. It works very strongly at the 5th receptor, which is relevant for people with ACTH tumors because these tumors tend to have a high density of that receptor. So this study was published in 2012, and it was the registry trial that was used that ultimately led to approval for this medication for Cushing's. It included 162 people with Cushing's disease, so these are just people with pituitary Cushing's, and they're randomized to 1 of 2 doses of this medication. And you can see this figure shows each person the reduction in their urinary-free cortisol that occurred. The red are the people who received the lower dose. This is 600 micrograms twice per day. It's given as a subcutaneous injection. And the higher dose, 900 micrograms twice per day, is in blue. Overall, the study showed that 13% of people in the lower dose achieved a normal urinary-free cortisol, and 25% of people in the higher dose achieved a normal urinary-free cortisol. And again, these are clinical trial data, so very different from the other studies I was showing where it's, you're just observing, looking back retrospectively or looking forward at anyone who received treatment. So this study also looked at clinical measures, and they found that there were clinical improvements. Blood pressure, cholesterol, weight, and quality of life improved. For the people who had a visible lesion on their MRI, and as I'm sure you all know, many people with Cushing's from an ACTH tumor, the tumor is too small to even be seen on MRI. But for those people who had a visible tumor, tumor volume decreased by 44%. So this, is good for people who want to have a tumor shrinkage effect. The safety of this medication was similar in terms of gastrointestinal side effects. Some people have nausea and diarrhea, similar to the other medications that we know, sandostatin and cimetidine. However, what makes this different from the prior medications in this class of medications is that it causes high blood sugars and diabetes diabetes in a lot of the people. Actually, 73% had an elevated glucose value. So this is kind of the main side effect with this medication that's of concern. In terms of predicting who's going to respond well, the people who had mild Cushing's tended to respond better. For the people with mild Cushing's, 50% of them had a good response. And you also tend to see pretty early on if you're going to respond. So you'll know typically within the first 3 months if you're going to respond. If you start it and there's no response, then typically you're not going to have a response later. So it's something that could be tried, and then if there's no response, move on to something else. Two more slides. So there's now a long-acting form of pasireotide. This is given as a monthly injection. And this is the clinical trial that was just published last year. It included 150 patients. Again, these are Cushing's disease patients. And they found that 40% of them achieved a normal urinary-free cortisol. The side effects are similar to the short-acting pasireotide. And the reason why this looks like there is a better response, 40% compared to 25% in the short-acting studies, because they had a cutoff of UFC for entry into the trial. So this, on the whole, these were people with milder Cushing's. And we knew from the prior study that people with milder Cushing's had a better response to the medication. And finally, a study that was just published by Dr. Fliserio and colleagues. This was the extension trial of the prior trial. So this was an open label extension, and it included 81 out of the 150 people who were included in the prior trial. You were eligible for the trial if you had a normal urinary-free cortisol or receiving clinical benefit from the study. And they found that about half the people had a normal urinary-free cortisol at the last assessment. About half of the people discontinued the medication during the trial. And in terms of side effects, it looks pretty similar to the short-acting, and there are also clinical improvements seen with this medication. You can see here the decrease in waist circumference that was seen on treatment. And there are no new concerns in terms of safety that came up with this trial. And this medication is now approved for Cushing's. That's all I have.
Hi again. I'm Adriana Akimascu. I'm from Emory. Let me see how I was doing things yesterday. Okay, very good. So we're talking about cortisol receptor blockers, and I feel that this is going to be like switching gears a little bit in terms of mechanism. And I would like to first tell you that this medication, that is the only one approved by FDA in this class, is called mifepristone. It was approved in 2012. To control hyperglycemia secondary to hypercortisolism in adult patients with endogenous Cushing syndrome who have either type 2 diabetes or glucose intolerance, failed surgery, or are not candidate for surgery. So one of the things that are underlined there is Cushing syndrome. So we're not talking only about pituitary disease, we're talking about tumoral endogenous hypercortisolism of any etiology. It is contraindicated in pregnancy, and it's all administered as tablets in doses that are up-titrated from 300 to 1,200 milligram per day. So, as I said, it's the mechanism is a paradigm shift for those of us who've treated Cushing's for quite a while, because it blocks the cortisol receptor. And for the purposes of demonstration, I'm going to show you some doors, which to me are the cortisol receptors. So some of these doors are locked by this medication, and think about it as like the keyhole is gone, but some are still open. So not all doors are locked, not all cortisol receptors are blocked, because cortisol is essential for life, so that wouldn't be a good thing. So this is how the mechanism is on the receptor at the cell level, and as a result of this, cortisol, which I'm going to depict here as this very nice golden key, there are more keys around. So when you measure the cortisol in the blood circulation, unlike any of the other drugs that you've heard up until now, the cortisol level is going to go up. And this is where the paradigm shift is, because for any of us endocrinologists up until we started to deal with this, we were thinking about clinical manifestations of Cushing's and cortisol level going in the same direction. So with this medication, it is absolutely expected for the cortisol level to go up, because there are many of these keys that they don't find their keyhole, right? So since we've talked about mechanism, I think we could explain one of the side effects with this analogy that I've created. So there are many keys, and some keys may fit in other key locks, in other keyholes, and that's why I represent it with a different color. And that's the mineralocorticoid receptor. So the excess cortisol in the circulation, some of those keys that are not used, may be able to open other doors. And with that, those of you who have been on mifepristone, you may understand why sometimes with this medication, you can have some leg swelling or low potassium, or sometimes even increased blood pressure. Mifepristone blocks other receptors. Is not just the cortisol. So progesterone is one that is blocked, and that's been known for a long time. Gynecologists were comfortable with using this medication way before endocrinologists became aware of this. And the problem that may occur in any woman of any age who has a uterus is vaginal bleeding and uterine endometrial thickening. So my patients who go on this medication see their gynecologist first and get their clearance. And then finally, we can have manifestations of low cortisol. And because many of those doors are locked, we need really high dose of a different kind of glucocorticoid or steroid, and we need dexamethasone. So those patients who have taken mifepristone, they know that we also prescribe a rescue medication for them to take in case of acute illness, especially with fever, chills, hospitalizations, or for procedures. And there are other side effects that can be observed, and as you see them listed, for those of you who have adrenal insufficiency, you see that some of them may occur as manifestations of low cortisol: nausea, fatigue, headaches, joint pain, dizziness. So that's where a really important understanding of the mechanism of action and a really thorough clinical evaluation from a physician who's experienced to using this are in need. Mifepristone does not affect tumor growth, so from what you've heard here, there are medications that affect the pituitary tumors, but others that don't, so mifepristone is in the latter category. So monitoring the imaging, especially for those patients who have pituitary Cushing, so a pituitary tumor, is important because it's not a mechanism that happens there. How about efficacy? So it's been proven by all the studies that it improves glucose control. It improves blood pressure in about 35 to 40% of patients who had high blood pressure when the medication was started. It improves other manifestations of high cortisol, including body weight, body composition, waist circumference, appearance, strength, moods, and quality of life. All those have been found in the clinical trials that led to its approval. And I want to show, I don't have any graphs to show about urine-free cortisol going down or anything like that. I've already told you that those levels go up, right? And I cannot show you tumor shrinkage data. But I think the graphs on body weight are relevant. What you see in the upper part is the seismic study, so the phase 3 trial that was led to its approval by the FDA. So more than a third of patients lost 10% or more of their weight. So if they started with 200 pounds, they in the first 24 weeks of treatment, they lost 20 pounds. And majority of patients, 62%, lost more than 5%. And what you can see in the graph that is shown up here is that, and this is the baseline, this is the weight at baseline, and then you see here the mean of all the patients included in the study, and then you see how far are the person who lost the most versus the person who lost the least amount. So as time went by, in the first 24 weeks of treatment, there was additional weight loss. And then more recently, on the patients who continued to be in a study that was called the long-term extension study, what you see here is that pretty much they maintain the overall about 9% weight loss from their initial baseline weight from here that was achieved in the first 24 weeks. So the results at 24 weeks in most patients, 80%, were maintained after 24 months, 2 years. How about dose titration? How do we go about this? Well, it's about clinical evaluation, right? That you cannot go by much else. Is the patient feeling better? Are they tolerating the new medication? What is the weight? What is the blood pressure? What did the home glucose records show? So how about cortisol and HGH levels? Are they helpful at all? Well, if you check them and they are elevated, it pretty much tells you that the medication is doing what's supposed to be doing. But at this point, we cannot use them in a specific mathematical way to help us adjust the dose. We just know that it's supposed to happen, but we're not quite sure how to use the actual numbers. But should we be doing tests? Oh, yes, definitely we should. So chemistry panel, in particular, potassium, creatinine, and glucose are very important variables that we have to monitor. Hemoglobin A1C, which is the average glucose number. Thyroid tests, because there is a proportion of patients who either start requiring thyroid medication or require an increase in their thyroid supplement dose. Lipids can change, and then EKG should be done periodically. Changes in concomitant medications. As you heard about other drugs that were discussed here, there is potential for interaction with other medications. So that's one aspect. But the other aspect is most patients who go on mifepristone will require some sort of medication to preserve potassium, either potassium supplement or medications that preserve potassium. So the need for potassium supplement becomes more significant as the dose is up-titrated. And potassium is helpful in particular to the muscles. It's good, and the heart is a muscle as well. So both low and high potassium levels can be dangerous because they can cause the heart to malfunction. Blood pressure medications. So remember that blue door and the aldosterone effect and so forth. We have ways to deal with that. There are water pills, diuretics, that decrease the aldosterone effect, and they are helpful in women with Cushing also because they can decrease their skin manifestations like acne and hirsutis. It's a little bit different for men, but for women who are not conceiving are very important medications. And the usual diuretics that usually work for high blood pressure, like hydrochlorothiazide, may not be needed in the Cushing patient. Blood pressure medications that can cause edema may need to be decreased or stopped. And insulin and anti-diabetic medications are usually reduced, and some patients are able to get off insulin or get off treatment altogether. In terms of patients who take this medicine, I think they have to have a proactive attitude and to seek immediate advice for acute illness, because that's the time when that rescue dexamethasone might need to be used. If the mifepristone is stopped, that's not going to change anything right away because it's one of those medications with a long duration of action. So, taking dexamethasone at the same time is actually essential. Procedures under general anesthesia, if they're elective, if they can be planned, that's a good thing to talk with the endocrinologist about that. New medication started by other physicians, urgent care visits, emergency room visits, and so forth, those need to be run by the endocrinologist who's prescribing. But bleeding, uterine bleeding, that's important to run by the gynecologist immediately and to let the endocrinologist know. Significant weight loss. So there are patients who lose a significant amount of weight, and after a while, that medication dose becomes too much for them, and the risk of low potassium can be higher. So let's say one has passed those frequent visits every 3 to 4 weeks to up-titrate the dose, and now they only come every 3 to 4 months. I wouldn't let more than 3 to 4 months go by without being seen by the endocrinologist, even though it's great that weight loss is still occurring, because medication can need to be adjusted. And low potassium. If someone draws blood and tell the patient you have a low potassium, then obviously let us know. What's in the pipeline in this group of medication of cortisol receptor blocker? There is a study called GRACE, which is investigating the role of relacorilant. And this is a phase 3 double-blind, placebo-controlled study, and it's meant for those patients with Cushing syndrome who either have type 2 diabetes or impaired glucose tolerance and or uncontrolled hypertension. There is a difference between mifepristone and relacorilant because this latter medication, which is clinically studied now, does not block the progesterone receptor. And if you want more information, you can go to clinicaltrials.gov. And I think that's all I had to say. Thank you.
So I'm not sure if we have time for questions or not. What, Leslie?
Hello. Okay, we have time probably for 1 or 2 questions.
Short questions and short
definitely not
answers. So now I've intimidated everybody.
We got a question right here.
I can't see. Yeah.
So for that, I'm probably saying it wrong. Oh, thank you. The salidrostat, am I saying that right?
Yes.
Okay. Does that, I know that you said that it blocks the cortisol and it also helps manage aldosterone. So does it also does it have the ability to sort of shrink the tumors?
The studies that we did were for Cushing's disease.
Yeah.
So the drug works by blocking the adrenal steroidogenesis. So it has no direct effect on the pituitary tumors.
Got it.
We're
Okay.
looking in longer term because potentially as everything that's blocking that's why the ACTH is going up. So it will never shrink the tumors. So the only one that potentially can shrink the pituitary tumors. The reason I thought about it for adrenal might be a different story, but for pituitary tumors, you do not see any shrinkage with any of the adrenal steroidogenesis inhibitor or the glucocorticoid receptor blockers.
If it was an adrenal tumor, would you?
We don't know.
You don't know.
There are no
Got it.
studies, but formoterapone has been used, and there are some initial ideas, but no, it does
Okay.
not shrink the tumors.
All right, thank you.
Is that the same medication that they use on like dogs and horses and stuff when they get Cushing's?
No, that's a trilostan.
Oh.
That's
I was just wondering if it like if animals get the same medicine that we do.
Go ahead.
Yeah, so animals do get mitotane, or trilostane, which we don't use, which doesn't work well in humans. It's a different steroidogenesis inhibitor, but one of the drugs that we use in people, we also use in dogs and horses.
And what's that one called?
Mitotane,
Okay, thank you.
orthoparoprime DDD, like the DDT insecticide.
All right, I think that's it. Thank you guys very much.